Continuing with the cardiovascular pathology, the lecture today is about the high output heart failure. This is a less commonly occurring problem, but when it does occur and if the patient does present to you, you should be able to understand what it is and work with it. So first of all, high output heart failure, the definition is heart cannot provide enough blood, it cannot eject enough blood to nourish the body. But in this particular case, the problem is slightly different compared to the left and right heart failures. What is the problem? In left and right heart failure, the heart is damaged somehow, and so heart cannot eject enough blood that is needed, and the tissue's demand is normal. Here the tissue's demand is abnormal. Instead of asking for 5 liters for all the body tissues, the body starts asking for 50 liters. Now heart starts trying to give more and more, but 10, 15 liters, and then it just exhausts and it dies or gets damaged. So here the heart is normal, demand is more. That is the high output. So heart is trying to pump more and more, but still the demand is not met, and that is high output cardiac failure. Let's see how that happens. Let's start with the condition where the stroke volume is increased. Hyperthyroidism does it. So what will happen? So let's say this is a heart, and normally this heart will pump out about 70. So if this is the stroke volume that came out, let's say 70 milliliter is the normal, healthy. All of a sudden, because of hyperthyroidism, what happens is that there is more thyroid hormone, right, T3 and TH3 and TH4 available. That would do what? That would do two things. Number one, it would act on heart and increase heart's metabolic rate or activity. It would also act on the tissues. So when the tissues are under thyroid hormones, increased thyroid hormone influence, what would happen is these would start having increased metabolic rate as well. So when the tissue's metabolic rate is increased, what would happen? Lots of waste products will be produced, metabolites will be produced. That waste, will cause effect on the blood vessels, and blood vessels would start dilating or constricting. If you have more tissue metabolites, the autoregulation, we've done these lectures, the blood vessels will start dilating. As the blood vessels start dilating, the resistance to flow would reduce, and the blood demand, the venous return would increase, and that would increase demand on the heart to create increased ejection fraction or increased stroke volume. So that is the hyperthyroid. Normally it is caught early because patient has other symptoms as well, and hopefully they go to the doctor and they seek resolution, and this problem does not occur. But hyperthyroidism, severe hyperthyroidism, can cause high output cardiac failure where stroke volume demand is so high that heart cannot meet it. How about the vasodilation? So this is the blood vessel. So look, vasodilation, we have the arterial side, right? So this is the arterial side, and then we have smaller branches, then finally we've gotten capillaries and the venous side. Opposite of that, capillaries, venous end, then venules, then veins, bigger veins, and finally we go back to the heart. So this is the normal structure. If you dilate the arteries, arterioles, what will happen? Arterioles are the basic resistance vessels, right? They are responsible to create the mean arterial pressure, or the systolic and diastolic is produced by the aorta, but systolic is produced by the resistance from the the arteriolar constriction as well. So what if they are dilated? If these guys are dilated, there is so much blood just flowing now. There is less resistance, total peripheral resistance has reduced, and so more venous return would occur, and there is more venous return means there should be more cardiac output, and we'll have a high output failure if this cycle does not stop, if you do not intervene in time. When would that happen? One, beriberi, wet beriberi, more clearly. Why? What happens? So thiamine is an important cofactor in the ATP formations, the cycles, the ATP formation is dependent upon the thiamine's presence. When there is thiamine deficiency, there is less ATP. All of the thiamine problems, you can actually relate them to reduced ATP. So when the energy is not present, there are two types of problems that will occur. One, the heart itself doesn't have enough energy. Second, the tissue, the vascular system doesn't have enough energy. And when the muscles do not have enough energy, what will they do? They would dilate, they would relax. So when the muscles would dilate and relax, the diameters would open up, the vessel diameters would expand, and that would increase the blood flow and the venous return. Blood volume would increase to the heart, and heart would now have to pump. That is the Frank-Starling law. So heart tries to pump more, and then the blood comes back fast, and then it pumps more and it comes back fast, and that is a vicious circle that would end up killing the patient. So that is the wet beriberi. Similar mechanism with the endotoxic shock, that the toxins that are being produced, they cause effect on the smooth muscles, and they start dilating the smooth muscles, because the vessels think that I need to bring in blood here to clear this little infection in this area. What they don't know is that this is happening throughout the body, and so all blood vessels dilate simultaneously. That reduces the total peripheral resistance drastically, and blood just starts going back to the heart in a very fast loop, and that would be high output cardiac failure. So that is toxogenic shock. How about AV fistula? How about somebody picks up an artery, bypasses all the microcirculation, and connects it directly to a vein? I actually have come across a surgeon who accidentally did this, ended up killing the patient. He connected the wrong artery. He connected an artery to a vein accidentally, and the patient died. So here what's happening is that microcirculation offers resistance to the flow. That is how we control how much blood is going back. And imagine if you take the resistance out. Now that resistance can be gone, removed by, let's say, a knife wound. Somebody stabs someone with a knife, that opens up the artery and vein, and now the blood is just circulating through those. So that is one case where AV fistula can create high output failure. Another situation will be where there is a shunt for hemodialysis, and that shunt we want to actually by design create these kind of situations where we merge them, and if it is not done correctly, or if we're not careful, that can cause high output failure. Paget's disease, the bones are all brittle and breaking, and so the arterial supply to the brain, to the bones, and the venous drainage of the bone is just now filled with the blood, and the veins are just picking that blood and going back. So that becomes a channel which allows almost a shunt to appear, atrioventricular shunt. So all those would also cause high output failure. And how about the viscosity? How about if we reduce the viscosity of the blood, that would increase the velocity of the blood flow, right? So what maintains the viscosity? It is the hematocrit, it's the RBCs, which are the primary contributor to the hematocrit. They create the thickness of the blood, they create the viscosity of the blood, they drive the flow properties of the blood. If somebody is severely anemic, RBCs would go down, blood flow would increase, and if severe anemia is present, then the flow would be severe as well, and that can also create high output cardiac failure. So these are some pathologies that can cause high output cardiac failure. Hopefully you find that out earlier, you intervene and you fix it. Otherwise, this extra demand and extra work on the heart can cause ischemic damage to the heart or can cause infarction to the heart. Thank you.